Pleasure to be here in Cairo. Thank you, the organizers, for inviting me. And we are going to see what's happening in Uganda with regard to prostate cancer and MRI. So these are challenges with MRI screening for prostate cancer using the Pirads 2.1 version in an African population. I'm a radiologist. And I do lots of prostate MRI, prostate biopsies, and transrectal ultrasound. So what are the challenges here? We know that prostate cancer is the second highest, with us is the second highest incidence in Africa. In other words, after Zambia, we follow, and it's the commonest cancer in men in our population. So we know that our patients present late most of the time, and we know that screening is necessary for early presentation, as has been said already. And we do screen using Pirads version 2.1, which, as you said, was 2019 version. So we have found that after studying a couple of cases, we did a study, 99 cases, and we saw that Pirads has a lower accuracy in our Ugandan population compared to the Western population. And the question is, what are the factors, and how can we mitigate these factors? And what's the different? Are we dealing with a different type of prostate cancer, or is it the same prostate cancer as in the Western population? And what's the role of artificial intelligence in improving our cancer detection? And so this talk will deal on all those subjects. We have studies, 3 studies here, which are the basis for this talk. One is on accuracy of Pirads. The other one is on prevalence of chronic prostatitis in our patients, in our MRI population. And then second is distribution of Gleason 6 prostate cancer, which has already been alluded to, then to the role of MRI. And we shall see how those help to solve the challenges. So we did a retrospective study, July 2017, 2022, and we looked at 99 individuals. The age range is 46 to 90, with an average of 63. Most of them had a low PSA density of 1 to 0.07 PSA density. And machine, we use a biparametric approach. We don't give contrast medium. We've discovered this is equal as good as a multi-parametric MRI 1.5 Tesla Achiever Philips with surface coils, and diffusion-weighted imaging, and a B-value of 1500 is what we use. As has been said, should be more than 1400. Use 1500. So of those patients, they all underwent biopsy, and 52% of them had a positive histology. It was a truth-guided biopsy, sextant biopsy, and the majority Gleason score 6, which is in 58%, followed by Gleason score 7, which is 30%. And surprisingly, the majority of our cancers were in the transitional zone, 38%, and only 24% were in the peripheral zone, with both peripheral and mixture of the two in 38%. So rather unique setting here of cancers being mostly in the transitional zone. And the majority of our patients fell in a Pirads 3 category, 66%. And most of the prostate cancer was actually found in this Pirads 3 category. And we looked at our cancer detection rate, and you can see that compared to a meta-analysis, our cancer detection rate is much lower than what there is in the meta-analysis. So something is not working right with our Pirate system, with our cancer detection rate. Why are we lower than the meta-analysis in all those, in the different Pirates systems? And when you look at the area under the curve, we have an area under the curve of 67 compared to 75 to 85. So something is not right out there. Why is our area under the curve that small? Now we we did, by consensus, we agreed on the Pirads score. So it's not a single individual. And these are people who have had MRI, been doing prostate MRI reporting for more than 5 years with a high volume of about 3 to 5 patients a day. So very high volume in our center. But still, you can see that the area under the curve is less than what is desirable. We looked at the distribution of prostatitis, and in 91% of our patients, there was evidence of chronic prostatitis, those very same 99 patients. And so it's known that chronic prostatitis may lead to higher Pirads score than is true and may increase unnecessary biopsies. Not only that, chronic prostatitis may lead to increased number of assigned Pirads 3 lesions and hence more false positive. So could we be having chronic prostatitis modifying our Pirads scores here? And so this is what we see in chronic prostatitis, as you've already had linear spherical patches, but we have also noticed thickening and dilatation of the ejaculatory ducts, especially the left ejaculatory duct. That sign is something which we see in our patients with chronic prostatitis, has not been reported anywhere in literature, but we see that, and also we see atrophy and fibrosis. And that atrophy and fibrosis is mostly on the left side of the gland. Of course, you also have a higher, higher diffusion, brighter diffusion rate imaging, and also a lower ADC. And so looking at patients here with typical chronic prostatitis, you can see here the peripheral zone is supposed to be brighter, supposed to be hyper intense, but you see that here it is hyper intense. You also see here a diffusion weighted hyper intensity and a bit of hyper intensity. So this dirty looking prostate is chronic prostatitis. And here you see the whole prostate on the T2 weighted imaging is hyper intense, rather bright on the diffusion weighted, and also rather dark on the ADC, and this also is chronic prostatitis. It was a Pirads 2, and it was cancer negative. Here is the dilated duct. This is on the sagittal section here. This is compared to that with a cyst. The dilated duct comes and connects with the urethra at the vermontanum. And so here is the dilated duct on the axial section, the T2, and you can see that this left side is shrunken compared to the right side. This is the left ejaculatory duct, so it looks like most of the infection in our patients is on the left side. Question is why? And on the coronal is also here the dilated ejaculatory duct. So the ejaculatory duct, we are seeing it as a marker of chronic prostatitis. So what did chronic prostatitis do to our patients? False negative CF due in a patient with chronic prostatitis. Here is the prostate on T2 weighted imaging, and then you look here, there's not much to suggest cancer, neither on the ADC, but this patient had a histology of Gleason 6 cancer prostate at histology. And then here is the false positive. Here, this patient also has chronic prostatitis. You can see the peripheral zone is hypointense. You can see the ejaculatory duct here is dilated. And then you see here a lesion which is not so clear on the T2 weighted imaging. And then it is bright here on the diffusion weighted and also dark on the ADC. And we thought, and we gave it a Pirads 3. WAP scored to a Pirads 3, but then it was negative at histology. So again here we think that that the chronic prostatitis is acting here to mask the lesion. You don't see it so well here. And then here again we see a patient with a lesion there. Also, but look at the peripheral zone there. It is hypointense. This is chronic prostatitis. The duct is also dilated out there. And you see a lesion there. It is bright there. It's not so dark here. This was a Pirads 3, but then it was negative histology in this patient. And then a true positive here, again with chronic prostatitis. Here you see a lesion there, hypointense on T2. You see here changes in the peripheral zone of chronic prostatitis. You see a bright lesion there. You see also dark here on the T2. and sorry, on the ADC, and this was a true positive. This is a Gleason 7 patient. Then a true negative here. Again, here you see a patient here with chronic prostatitis, hyperintensity there in the peripheral zone. You see a lesion there. You should be, you can upscore a lesion here from a Pirads 2, Pirads 3 if you have a hyperintensity on diffusion rated and also marked hyperintensity on the ADC, which you don't have here. So we could not upscore this lesion to a Pirads 3. It still stayed a Pirads 2 because the ADC was not matching with the diffusion rated. And then this patient was still negative for histology. So that's a true negative. Now, here is a patient again. You see these streaks here of chronic prostatitis right there in the peripheral zone. You see a lesion there. Now, one may think that this is tumor also on the T2 weighted image and may think that this is bilateral tumor, and that would change the staging. But when you do the ADC, the diffusion rate and the ADC, this turns out to be limited to the right side. So here, chronic prostatitis can give you a false sense of tumor, bilateral tumor. But here you see that diffusion rated is helping you to sort that out. So chronic prostatitis in our environment really mixes up the picture. So now the question of Gleason 6 cancers, this is still debatable in some areas. But certainly Gleason 6 does not metastasize. I have not seen a Gleason 6 metastasize, but we've seen Gleason 6 having a local, extensive local spread. And so into stage 3, even involving the seminal vesicle. So is Gleason 6 clinically significant cancer? May we be dealing with a different type of prostate cancer in our population? Or are we under sampling there's heterogeneity in the tumor. You may see Gleason 6, Gleason 7 in one single patient. So if you don't sample properly, you may end up with a Gleason 6 only. So, but then here you can see that we analyzed 199 patients, stage 3 and also stage 4. You can see that in stage 3 there is, and also in stage 4 there is a Gleason 6 in our patients. Of course, the question is, we don't control the histology here. May we be dealing with a problem of quality control? But look here, this is a patient who was well sampled and had a Gleason 6, and you can see that the whole prostate is involved bilateral disease, but there's no disease outside the prostate, Gleason 6. Now this is a Gleason 6, and you can see this is a seminal vesicle, and so there is spread to the seminal vesicle, but then there was no tumor elsewhere, so there was no metastasis. So the question still remains, what do we do with our Gleason 6 tumors? So role of artificial intelligence. We have few radiologists in our center, and not many of them in our country, not many of them do prostate MRI. And even within those who do prostate MRI, there's a lot of inter- and intra-observer error and disagreement. And with chronic prostatitis and other things playing out there, could AI perhaps do better than the human? And so that's a question we set out to ask ourselves. And so we developed a machine learning framework to automatically classify prostate cancer using diffusion rate and ADC. And we are doing this work. My center is doing it together with Cairo University. And this is we developed the model based on diffusion weighted imaging and ADC. And this is the model architecture. I will not go into that because of time. But you can see going on fast forward that with this model, we have a sensitivity of 0.8 and a specificity of 0.75. So doing reasonably well there. At that time, when we wrote this out, we had 68 patients, but now we have, I think, up to more than 200 patients. So we are going to look at this model again and give it more training, patients, and also test it, because the larger the data set, the better the model. And it looks like that, yes, we may have a companion in AI who may work side by side with you to see how accurate you are, and they may be able to help us to triage which patients to put our mind on. That's the area under the curve for our testing for the model. And so the take-home message here is Pirads version 2.4 is less accurate in our 2.1 is less accurate in our population than in the Western population, and most prostate cancers are in the transitional zone. That zone is the zone of organized chaos. That's what they call that zone. So that zone may hide some of these prostate cancers, and most prostate cancers are in Gleason 6. Now you notice that Gleason 6, if you're a radiologist who's doing a prostate cancer, the ADC values are a little higher. You may get them either 800 and something, up at times 700 up, but certainly. So in Gleason 6, the appearance of the prostate cancer may not be as dramatic as in Gleason 7, 8, 9. So because of a low Gleason score in our patients, it's possible that some of these cancers are being missed. And so, but then we've seen that chronic prostatitis may modify cancer appearances. You may have false negatives and false positives. And then we have the question, what's happening? Why are we having locally aggressive Gleason 6 cancers? Is our cancer different? And we've seen that AI could have a promising role, but work is still in progress. Thank you, Mr. Chairman.
Thank you, Professor Michael, for the very nice presentation. I have just one comment, a question for you. Yeah. Just one comment. It's about the Gleason 6 scoring. Usually patients with prostate cancer and Gleason 6 scoring are having low potential of metastasis and low potential of spread. And this is why I am guessing that the problem might be in the pathology specimen readings. Maybe the pathology specimen readings are not somehow quality controlled as it should be. I'm not sure. What do you think the explanation might be?
I do think so, that there may be a problem there. There may be a problem there. It may be either in some of the sampling, the person doing the biopsy, that they don't sample the whole tumor and sample only a little bit because there's tumor heterogeneity within that tumor. You may have one part of tumor Gleason 6, another one Gleason 7. That could be the problem, or it may be the histology. And so one of the things we are doing now is to standardize, to try to standardize the way we do biopsies, and also the way we do histology. But for sure, some of these have been done by myself. And I do radical tumor sampling, and we have a radiologist in the US who double reads our, and we've seen some Gleason 6, not with metastasis, no, but with extensive local spread in the prostate, or at times even in the seminal vesicle, but not beyond. No lymph nodes, no bone involvement. Yeah. So the question is, what do you do with this tumor? Of course, the patients are anxious; they want it out, yes. And so it's still a debate. Okay. Thank you.
Thank you. Michael, I have another question for you, sir. Please, do you do this by biopsy, cognitive type, or transrectal only, or MRI guided? What kind of the biopsy that you take?
We do. We start by doing MRI, and then with MRI you are going to localize the lesion, and also that will also help you to know where you to focus. And then we don't have fusion, so you fuse in your head, and then you do that. You do the
cognitive time. Very good. Yeah.
Then you do that transrectal ultrasound, because same person doing it, and then you know where the lesion is, or not. You guide the one doing it precisely to the gland and to the, whether it's anterior or posterior, so that they don't make errors, and then they correlate what is on MRI with what is on ultrasound. But then you still biopsy the whole prostate, you do, but then you concentrate on where the nodule is. because you know that you have multiple tumors, multicentric. CA prostate is one of those tumors which occur in multiple areas, and so you need to sample the whole prostate in addition to sampling more the area of interest.
Thank you, sir. Thank you, sir, very much. Thank you, sir, very much. And now we're gonna watch a video from Professor Dr. Hein.